Hi, welcome to the IntualityAI podcast. And today we have a very special guest, Dr. David Katz. We'll get to him in a second. I'm Dr. Howard Rankin, along with Grant Renier, founder and chairman of IntualityAI. And in this show today, we're really going to address the future, which is what Intuality does, and how do we navigate this difficult future. Now, I'm very grateful for David to be here with us today. He's been very busy. He's a very busy man. He has incredible credentials. He was the founding director of the Yale Griffin Prevention Research Center, founder of the True Health Initiative, past president of the American College of Lifestyle Medicine. He's authored over 200 scientific articles and 15 books, the latest of which you need to look at, which is The Truth About Food. And while some people may be certifiably bored about preventive medicine, he is board certified in it. So, and the other thing is, while David has been making the headlines in national media, he's also been on the front lines working in the hospital. So thank you for that, David. I know that's not an easy position to be in. So welcome.
Well, thank you, Howard. Lovely introduction. Really appreciate it. Good to be with you. Correction, though, 18 books, and the latest is How to Eat, which is my collaborative effort with Mark Bittman. So,
I'm sorry about that.
That's quite all right. Truth About Food is second or third most recent. I mean, it wasn't that long ago, but
right.
But a couple more came out. So, How to Eat. And yeah, no, I mean, the front line's not easy, but honestly, what I did was a drop in the bucket. So, I was privileged to be able to help my colleagues out. I basically volunteered for a week's worth of clinical assignment and wound up doing 3 12-hour shifts in an emergency room in the Bronx. But, and honestly, it was intense. And everything about it was intense, but you compare that to people who are there all the time, who were there at the start and will be there through the end. And it was just a small contribution. And I never thought of it as more than that. And my hope was that I would be one of many thousands making a small contribution. And, if each of us gives a week, if there are 5,000 of us, that's 5,000 weeks of work. That's something, right? So I just want to be a very small part of what needs to be a large communal effort.
Well, yeah, great. Thank you. And did that experience on the front line change your views at all about how we get over this, or did it reinforce your views, perhaps?
Yeah, it really didn't change my views, Howard. I respected this disease from the start. And when I first started writing about this, I was saying, I think my very first piece was a column I did for, either did it on LinkedIn or for Heated. But, am I going to get coronavirus and die was one of my earliest. And I said, I'm looking at the data from South Korea and China. And it looks to me like this is a really bad disease for a relatively small segment of the population. People who are elderly, people with chronic disease, and especially people in both of those groups. So older people with chronic disease, this is a bad actor. And we've got to respect that. On the other hand, it looks like it is overwhelmingly likely to be mild in young people free of chronic disease. And that experience was absolutely borne out by everything we've learned since and reinforced by the ER. So in the ER, there really were 3 groups. This was a busy emergency department in the Bronx, and New York City really is the epicenter of the epicenter. And the US is the hardest hit country, and New York City is the hardest hit part of the hardest hit state in the hardest hit country. So, it's a pretty good window to what's going on. And, we had case after case by ambulance from the nursing home. And to be quite blunt about it, most of these people were going to die. Some of them died in the emergency room. Some of them got to a bed in the hospital, but were very likely to die there. This is a bad disease in frail elderly people. Now, the other thing about the ER, I worked as an emergency physician in the early days of my career, and we always got ambulance after ambulance from nursing homes. I mean, the thing about frail elderly people is, they're prone to get acutely ill and to die, with or without a pandemic. But what COVID is doing is consolidating that. So it's all happening at once and everybody has the same diagnosis. Whatever else anybody had, their admission diagnosis was COVID. And so that absolutely reinforces the need for social distancing, shelter in place, flatten the curve, avoid overwhelming the medical system, because that potential was there. Then there was another group of people who were showing up in the emergency department for whatever, back pain or laceration. And oh, by the way, when tested, they had COVID. They had no awareness of it, no symptoms of it, and they got sent home. So it was a mild disease. Often people were oblivious to it. In fact, the hospital I was working in started testing everybody coming into the obstetrical ward, and 25% of the women coming in to have a baby tested positive for COVID. And this despite a pretty high rate of false negatives, by the way. So I think it's actually higher than that. But 1 in 4 women coming in to give birth had the virus, no symptoms whatsoever. Some of the neonates were tested and positive, no symptoms, no clinical manifestations whatsoever. So reinforce, this is 2 very different diseases in people vulnerable to the severe forms, people most likely to get the mild forms. And then there was a group in the middle. And the group in the middle is what tends to make the paper and what tends to cultivate all of our anxieties. So for example, I'm trying to get an update about a guy that I was involved in admitting, generally healthy, 50 years old, so my demographic, but younger than me, who came in after 2 weeks of symptoms, tested positive, and after 2 weeks was suddenly getting worse. That scares the hell out of me, because that's one of the quirks of this disease, is sometimes after it seems like you should be just about through it, it takes a sudden turn south and things get really bad. So my view from the start was, yes, I respect this pathogen, but no, I don't think it's, the infectious apocalypse. And I think most people will get this thing and never even know they had it. And exactly that view was reinforced by 36 hours in a busy hospital emergency department.
Yeah, interesting. And I want to introduce Grant Renier here to you. And Grant has been through his AI process, which actually takes into account certain key cognitive biases are factored into his analysis. And Grant, perhaps you'd like to show and tell David and the viewers about that latest graph of deaths and cases in the US that you or Intuality produced.
Okay, I'll give a little bit of a preamble here in terms of how we got here. I've been working through my career in various ventures on a type of AI that simulates human decision-making by simulating the subconscious biases that we use to make decisions. And it all sounds like a lot of gobbledygook, but that's what we do, and we have had fairly good success in many different areas, in the markets, in sports, and particularly in health. And so when in elections, for example, so when this occurred, I was looking around to see who was might be making some predictions, that is, graphical predictions driven by predictive analytics, computer predictive analytics, about where this thing is going. And that happens to be our specialty. We don't necessarily report status. We're interested in trying to predict day by day out into the future what's going to happen. So what I want to show is some of our results. And incidentally, as far as I know, there's no one else doing this other than maybe the University of Washington, or possibly private organizations that are keeping the information to themselves. We're making ours free for anybody on our website and through the podcast to use as they will. We're tracking about over 500 different countries and municipalities in the world, and we have charts for every one of them. So I'm going to just show you one of them here. This is going to be for the United States, if you can see that. This is a prediction of the COVID-19 cumulative from April 27th through August 4th of 2020. And these are the US cases that we predict. It's right down at the current level, pretty much in line with what the current cases are that are being reported. And as you can see, the system is predicting a continued growth in cases as we go forward, all the way out to about August 3rd, with some leveling off in this period in here. And that's interesting, and I'll come back to that a little bit. But that's basically what the system is predicting. And of course, predictions are predictions. They can be wrong. And every time we update this automatically updates itself every day. And these curves will change. So the next one that I'll go to is the number of deaths in the US. And this one starts about where we are right now and goes up and plateaus right about 86,000 deaths in the US, and then sees a very definitive leveling off. As you can see, it grows a little bit. It's hard to visualize it here, but it's predicting a leveling off starting at about the latter part of June. And so that's a little different than what people are reporting, but that's what our system is coming up with at this point. And then the other interesting part, of course, in the worrisome part is that it is predicting what might be a second wave that might occur in the latter part of July. And so this curve, especially for deaths in the US, haven't seen anything like it or any curves at all that do this sort of projection. And of course, we do this, it's automatic every day. It's free for everybody to view on our website or through the podcast that Howard and I are doing. In addition to this, we picked out just for this, this meeting that we're having now, the seven states that are having at the top of the list, basically, in terms of the number of cases. And through the color, you can identify who is who. And of course, the green one right here is New York State. And you can see, again, over the same time period, starting from roughly today out to the 1st of August, roughly, that doesn't seem to be any let up. There's somewhat of a little bit of a reduction in midsummer, but it continues to go. Other states are down here and they all look pretty much the same. This incidentally looks a lot different than it did a month ago when these curves were exponential going up. Now they're much more flat. So that's probably the good news. And then go to the deaths over the same time period for the same states. And you can see, for example, for New York, we're predicting a flattening of the curve, basically, around the early part of June. But then the worrisome part is that it kicks up again in the latter part of June, actually. And there's some of that occurring here in the other states as well. So we do this, as I say, we're tracking over 500 different countries and municipalities within them, and for the world as well. And there's too much to present in a meeting like this. We hope to have people, if they want to know a specific, if they want to see a specific chart for a specific country, let us know, and we can put it on our website. It'll be free of charge. It's to be can be viewed by them at any time. So that's our technological take on what's going on. It's backed up by basically 40 years of development of this particular kind of AI that we specialize in. And I should say, it's just for a side note here, it's in the category of calling artificial general intelligence. That is, the system, the core engine or the brain doesn't change how it operates from either the markets or sports or elections or, in this case, health. And so it's a very reliable system for us over a good many years. So If you have any questions, I'd be glad to answer them. I don't want to bore anybody with lots of statistics here, but
Well, one question would be, I think a few comments are important. One is the number of cases probably is going to go up simply as a function of testing, I would think. But that wasn't factored into this. David, I'm just interested in any reaction you had to those predictions.
Well, first of all, Grant, thank you for the work and thank you for making it publicly available. We actually have a lot of risk models on our website, truehealthinitiative.org. Some of the world's leading risk modelers have collated that information. That's all in the public domain. That, however, is different from what you've done using artificial intelligence, which is fascinating. And at some other time, I'd love to learn more about what's gone into the back end of that.
absolutely.
But anyway, appreciate the work. Thank you very much. I do have some comments. First, obviously AI, or for that matter, NI, natural intelligence, to the extent that exists in our species,
Right.
it can only process the information made available to it. And so these models all change based on what we do. So, essentially what you've done is looked at the world as it is and the way people are behaving in the world as it is, and this is where it would take us. And I think that's probably right. But I think there are a couple of potential liabilities in the data flow into the models. One is, I think rates of infection are massively higher than we've been able to confirm, because most of the cases are asymptomatic. And unless you do systematic active surveillance in the population, you don't find the mild cases. You don't tend to miss it when somebody needs an ICU bed. That's pretty flagrant. You certainly don't tend to miss it when somebody dies in the middle of a pandemic. That's pretty flagrant. But if somebody feels fine and never gets tested, it's easily overlooked. If someone has mild symptoms they don't bother to tell you about, it's easily overlooked unless you go out and get it. And so, in New York, for example, there's now evidence to suggest 20% of the entire population of New York already has antibodies. Well, that's 4 million people already infected in New York alone, to say nothing of the rest of the country, right? So everything changes. Well, okay, then if it turns out that millions have already had it, and the mortality we're seeing is a tiny fraction of the millions, all the models change.
Sure.
And I think that's true based on, so my natural intelligence tells me massive amount of undetected mild disease, because that's the part of every epidemic you overlook.
Right.
It's like an iceberg. Every epidemic is like an iceberg. What you first see is what's sticking out of the water: severe disease and people dying. You don't miss that.
Right.
You have to go looking for the part under the water. So there's that. And then, the mortality issue really depends on what we do. And what I've argued from the beginning is, we know for sure that this is a bad actor in certain groups. Let's double down on protecting them. Let's do everything we can to identify them. So, let's not assume that what's true in South Korea is true in the United States. Let's get our own data. Let's do representative random sampling of the US population. Who is infected, who has been infected, who's made antibodies, and essentially put together what I've called a data pyramid: total infections, total immunity, total hospitalizations, total ICU, total death. And how does all of that compare to age distribution, presence or absence of type 2 diabetes, presence or absence of coronary disease, presence or absence of, and the list goes on from there.
Right.
Because then we're able to make, I think, better informed projections about not just the data you provided, cases and deaths, but the other critical issue in all of this, and this is really the main argument for flattening the curve from my point of view: we do have limited capacity in the medical system. What we don't want to have happen is so many people get severely sick all at one time in one place that, it's horrible to die on a ventilator. It's that much worse to die for want of a ventilator. And we're really worried about that. And that requires we know not just deaths and cases, which are at the two ends of the spectrum, but how many people get hospitalized for every death or for every case, how many people need the ICU for everyone who gets hospitalized, and how many wind up on a ventilator, and for how long. One of the things, Howard, back to your question about the hospital, one of the learnings, and this is partly just from data and sourcing material out in the world, and partly from conferring with my colleagues in the Bronx. But one of the important learnings about this disease is for everybody who dies tragically, there may be 30 people who spend a month in the ICU and then they make it out. But that's the real problem here. I mean, again, old, frail people, are prone to wind up in the hospital and die. But a month on a vent in the ICU, that's very unusual. And if that's a 30-to-1 ratio, this business of we've got to flatten the curve because our hospitals can be overwhelmed, totally valid. Really, really important. So, again, I think this is fascinating. I think it's great work. I really appreciate it. But, I think there's plenty of debate to be had about how reliably do we know the number of cases,
Right.
and how reliably can we predict deaths based on the number of cases when the number of cases is probably a huge unknown at this point.
Well, I totally understand what you're saying. The biggest problem that, and I'm sure you know that we have, is just trying to get the data.
Right.
And I think that the surprising thing in this particular effort over the last number of months here for us has been, quite honestly, the surprising lack of data coming from our governmental organizations compared to the rest of the world.
Yeah.
We're just knocked over by the fact that we have to go hunt and seek out this stuff. Most of our data, well, all of our data is coming from private organizations,
Right.
first of all.
Right.
None of it is coming from a governmental organization. And that's the first problem. Well,
Yep.
it's quite different in other countries. And we can talk about that forever as to why that happens that way. But the other thing is that, so we're victim to the data. The system would love to have all the data it can possibly get,
Right.
especially what we call influencer data. And this isn't, there are two categories. One is objective data. Objective data in this case is number of deaths, number of cases, and so forth. Influencer data is all of the other things that you've been talking about, that if we could have that as well and feed it into the system, it could make its judgment about and further refine, hopefully, the objective of it in terms of trying to predict deaths and cases. And so that's one of the big battles that we've had here, trying to find and get access to good, reliable data.
Yeah.
And it's kind of, I've been in IT my whole career, and it's kind of embarrassing in this particular situation to realize that we're having to hunt and seek this stuff out, and it's not good enough.
No, and we all agree, terribly rate limiting. And, I keep having interviews where we're using analogies like, flying in the dark, flying through dense fog, the fog of war, because, essentially the light that will guide us through this is data, is knowing what's going on. And we're basically, again, whether it's our native intelligence or artificial intelligence, the best models we can build are still limited by the inputs, and
Absolutely.
The inputs are so constrained, and that really, it's a failure of our federal leadership to get that job done, and scrambling to catch up now. One of the points that I've made, and others I respect very much have said similar things. You hear that we simply don't have the resources to test millions of people, but so what? Representative random sampling will enable us to extrapolate to 325 million with a test in 10,000. I think it's the work of 72 hours, honestly. You basically deploy mobile testing units, you work through many hubs, either, you work through academic centers or prevention research centers, or, but the CDC can coordinate. They use these methods all the time. There are national surveys that are entirely predicated on representative random sampling. Everybody knows how to do it. Frankly, call in the National Guard to do the testing if you need to, so you get it done quickly. It's that important. It's a matter of national security. 10,000, 20,000 people, 72 hours, analyze the data, ask them a few questions about age, sex, height, weight, health status, zip code, and we've got massively better data. But based on what we do know, again, yes, I think, cases are going to go up. Deaths are going to go up, but I think cases are much higher than we know. I think the case fatality rate is much lower than it looks like. And I think, and this is, it's controversial, but probably shouldn't be, if that's true, then, you actually want the low risk people out in the world. You want low risk people to be exposed because, you know, it's basically like any other circulating infection. Most of us are going to get it, get over it, make antibodies. And then that becomes the way to prevent that second surge that all these models predict. If we continue to shelter in place and social distance and try to stay away from it, it means a lot of us stay vulnerable. And that anytime we loosen those clamps, a lot of us get it. And then potentially we pass it on to highly vulnerable people who don't just get it, but get it bad and potentially die. And all these curves look pretty ominous and tick back up. On the other hand, if we say, no, actually, we can risk stratify now. We have a pretty good handle on who's at low risk already. We could do a better job with representative random sampling. And again, we could know that in a week if we committed to it. So let's find out. And then let's phase people out in the world with the explicit understanding that you're probably going to get this thing, but it's probably not going to hurt you, because that appears to be the case for low risk people. Now, we can't guarantee that. Sadly, some young people will get severely ill. Some young people will die, but, you know, frankly, that's true crossing the street. That's true riding a bike. That's true driving in a car. That's true of the flu. That's true of risks that populate the experience we call living. And, you know, we'd love to offer people a guarantee that, you know, nothing bad's ever going to happen to you out in the world because you're young or you're healthy. Alas, life doesn't work like that. But what we can say is for a population that is appropriately risk stratified, the risks of COVID-19 fall well within a range of stuff that you're exposed to every day, all the time, every year. And they're risks that everybody seems to be willing to take. We don't shut down society for seasonal flu, for example. So that group out into the world, you're probably exposed. Most of you may not notice. Some of you will have a mild infection. And then we basically monitor cases, but not deaths, because the deaths are not happening because we're continuing to keep those most vulnerable protected away from the virus. And then I think, you know, the goal becomes herd immunity. So a high caseload, but a low fatality rate. And then we track the development of antibodies. And when there's near zero viral transmission and a high rate of antibodies, everybody's grandparents once again get to hug their grandchildren without fear of infection, right? I mean, that's the goal here. We want to minimize the harms of this damn contagion. We want to minimize the harms of massive unemployment and poverty and food insecurity. And I think of people like my 80-year-old parents, and I would really like to know for sure that my mother gets to hug her grandchildren again before she dies of something else while sheltering in place, right? I mean, those are the goals of what I call vertical interdiction.
Yeah, and I think that's important because it's so, you know, the default setting is sort of binary thinking. It's either one way or another, and all that leads to is polarization, and you see that shocked and amused.
It's how not to think, Howard.
How not to think. That's exactly right.
We specialize in how not to think.
To think, we do, yeah. I mean, for example, I mean, hey, you see all of these posts from people on social media that say, hey, I've had COVID and I've recovered and it was no big deal. But I've not yet seen a post from somebody who said I got COVID and I died.
Exactly. Yeah, they tend to post.
So,
yeah,
you know,
right.
so the availability bias will tell you, oh, all I'm reading is people surviving. Yeah, it's nothing to it. Let's all go out and play, right?
And at the other end, you know, what you basically do get such doom and gloom. I mean, essentially what the media do. My friend John Tesh says, if it bleeds, it leads. So, you know, if one young person gets this and dies, I guarantee you, you know, headlines everywhere. What you won't get is the denominator, you know, but actually, you know, it looks like 10 million people in that age category have this, and, you know, all the others were fine. And by the way, you know, one young person died of some bizarre cancer this week too. You know, all the other things that are anomalies that affect young, healthy people, they don't make the news, but COVID does. Exactly. So then you get basically nonsense in both directions. You either get everybody has to hunker in a bunker indefinitely until, you know, we have a highly effective vaccine or die of something else, and life, as we knew it, by the way, is over. Or, you know, everybody back in the water, including grandma and grandpa, and never mind the riptides and the sharks, you know, it'll be okay. No, I mean, I absolutely reject both of those poles, and all along have seen a way through this right down the middle. But again, our society specializes in how not to think. And so, you know, I think we're basically blinded to that middle path.
Yeah. Well, I think that and again, I come from the data side, but understanding cognitive science and so forth, understand that part of it as well. I guess the most frustrating thing is that we just need more data. We know what we can do if we have more data. And making predictions out in the future becomes a huge potential planning tool for everybody.
Right.
The more data we get, the better the predictions can get, and the more specific kinds of planning people can do in your field, the whole area of healthcare and public service and all the rest of it. That's the big Achilles heel right now, and it may be that there are organizations, both public and private, that have a whole lot more data than we're able to get our hands on. And it would be very nice if in a particular crisis like this, that they could see their way clear of making that data available. That would be a huge plus, I think, for everybody.
I totally agree, and I don't know when the U.S. is going to get caught up. I do know there's an effort well advanced in Israel to do representative, weighted, random sampling to test for infection and immunity. And again, I don't know quite what the timeline looks to be. I also know, and to the extent that I've had access to the process, I've said, make sure you get information, not just about age, sex, and location, but it would be really helpful to know BMI, because that clearly appears to be a risk factor. It would be really helpful to know diabetes, yes or no, heart disease, yes or no, hypertension, yes or no. So if you can get that information, make sure you do. Even then, you really do want homegrown information. The epidemiology varies to some extent by country. And the age distribution of those risk factors. So we have higher rates of obesity among younger people in the U.S. One of the things I don't know, and I'd really like to know, is how do the different risk factors interact? So so I don't think they're just two risk tiers. I don't think it's just low and high. I think the highest risk group is older people with chronic disease. The lowest risk group is younger people in perfectly good health.
Right.
But in the middle, you've got young people with not quite perfectly good health, and then you've got slightly less young people with better health, and slightly less young people with slightly worse health. I think you could get pretty granular and say, depending on how we want to lump or split here, we've either got low risk and high, or we've got 27 grades of risk. I don't know what it is exactly, but it's more than two. And then how do you want to build national policy around that? Do we actually go back to the world in 27 distinct phases, or do we say, no, actually we want to bundle that? It's basically 3 groups of 9, relatively low risk, relatively medium risk, relatively high risk, 3 phases back to the world. But it would really be helpful to have data representative of the population for which you are devising policy. And we're so far behind here.
Yeah, and this can tie into the whole discussion argument that goes on about providing health service, public health service on a total population basis. I'm not sure there's been enough discussion about what would be really advantageous, and that is the creation of a governmental-run public database of all of the kinds of health information that you're talking about. There are reasons why some of it is protected, of course, for privacy, but that doesn't, so much of it can be available without violating privacy concerns. But that national database would, if it was made available for everybody, private and public and governmental, would open up all the people that are in my particular field of technology to just do some pretty fantastic things. For example, just the things they're talking about. What is the relevance of, let's say, what is the relevance of age groups to the infection rates of COVID? The system, if we had that information, would be able to determine that for us and make its best guesses to the relevance of it. And that's paramount in importance, I think, stuff like that.
Yeah.
And the technology is there to do it. So
Totally agree. Yeah, I mean, I love the idea, first of all, the national database, and conjoined to that national clearinghouse where, people can play with risk models, source material. Some of these models, as you know, are interactive. You can basically, some of the risk projections, you can alter the assumptions and see what that does to hospital beds you need or ventilators you need. And then I've been inundated just because of my visibility on this topic since showing up in the New York Times and since Tom Friedman chose to channel my thinking in his column. Uh, Privilege, it's also been a bit overwhelming, the volume of creative ideas that have found me. And okay, but it's lovely, but I'm just one guy. I mean, I don't know which are good and which are bad. I mean, sometimes it's obvious, sometimes it's not. There ought to be a national clearinghouse for innovation and for best practices. And, I mean, if I ran the zoo, that would be an obvious one where you say, let's have, a group of masters in public health, trained to curate this, so only the legitimate, promising ideas see daylight. So we don't post suggestions about injecting Clorox into your eyeballs, for example, but everything that's vaguely legitimate, that seems like it may have promise and is worth trying out, gets posted there. There are a lot of experiments going on in hospitals around the country, clinical experiments. I mean, we're not talking about, randomized controlled trials. There isn't time. We're talking about clinicians saying, desperate circumstance, let's try this. And then they've got to kick it, an N of 1 or an N of 3. But when it looks promising, that ought to see daylight early. I was amazed. This is another thing back to the ER experience, Howard. I was hearing from my colleagues, we are treating these patients radically differently this week than last week. I've never seen a situation in medicine where that was the case. These patients, I was looking on and I said, no, we would have intubated this guy last week. Another intubation would have wound up on a ventilator. We're not doing it. And I watched how patients who would have been intubated just a week prior were not intubated and got better in an hour. Because they've learned that actually intubation itself and machine ventilation tends to exacerbate the course of COVID-19.
Really?
So when you have to, but if you can avoid it, you try like hell to avoid it. And the combination of, different means of administering high flow O2, repositioning the patient, active avoidance of intubation, no question was saving lives. And this was a radical change in clinical practice in the span of a week. And in my entire 30-year clinical career, I've never seen anything like it. But that's, it's playing out that fast. So you really want, what are all the good ideas, and let people shop them. And, then basically if everybody is sampling everybody else's best thinking in real time, it becomes like a series of filters where, the stuff that's promising sees daylight and everybody tries. Well, now this is the next tier where the stuff that we've tried and filtered out those things that didn't work all that well. We rapidly evolve in the direction of standardized best practices. And we can save a lot more lives. I mean, the treatment protocols have improved massively just in the span of weeks.
Yes, this is a learning process. And by the way, of course, the database that you're talking about, or the sort of database, would be valuable in its own right, in terms of lifestyle, medicine, and outcomes. And we should be doing that anyway.
And there is some of that, the behavioral risk factor surveillance system, it's not entirely easy to access or play with, but it is available to researchers. You can do secondary data analysis. And so these are representative random samples of the US population conducted by the CDC, looking at, as the name implies, behavioral risk factors. So dietary practices, physical activity, so forth. So, we have some of it, but what we're talking about really, is a much more useful, fully realized public good. And totally agree. It would be valuable acutely. It would be valuable over time.
Oh yeah, I think that the barriers to it are substantial. Systems like Epic and so forth, and the HIPAA regulations and so forth are sometimes difficult to penetrate, for privacy concerns. But from what I see, we don't need to know people's names and addresses. And so it seems that in a national health system of some kind, a major function should be the establishment of this database, and opened up to not just PhD researchers in institutions and in medical centers, but to everybody, to the mathematicians of the world, to the IT people in the world, and let them go at it. And there's no reason why that shouldn't be done.
Yeah, amen.
Well, David, I know you've got a lot going on, so really appreciate the time you've spent with us. Awesome to have you on the show. I personally agree with you that this is the way to approach opening up. Obviously, it's an evolving situation. You'd have to deal with, unexpected things that will inevitably come up, but you've got to start somewhere and you got to have a plan forward. So
Thank you, Howard. And
appreciate that.
yeah, that's it's another, just a final comment. That's another thing about clinical practice. We never have perfect knowledge. We never know for sure what's going to happen with a patient. We always wish we knew more, but you can't do nothing, because actually doing nothing is fraught with consequences. Sometimes doing nothing is the most lethal thing you could do.
Yeah.
So the idea that you use the best available information, make the best decisions you possibly can, and then stay light on your feet. So if you learn more and can do better, you adjust. And I think that's how we handle this pandemic too. But thank you. It's a pleasure to be with you both.
Great.
Thank you
Thank
very
you
much.
again. Take care.
You too.